This chapel reminds me of a story I recently heard about a seminary student who came into church on Sunday, sat down in the pew, opened up the program, saw who was going to preach that morning, guest preacher, turned to the woman next to him and moaned, "I can't believe who's preaching here today. I have that person as a professor at seminary, and I've had to listen to two of the most boring lectures I've ever heard already this week, and now I have to sit through his sermon here as the guest preacher on Sunday." The woman turns to him and says, "Do you know who I am?" He says, "No." She says, "Well, I'm that boring professor's wife." Stunned silence for a minute. Then he turns to her and says, "Do you know who I am?" She says, "No." "Good," he says as he runs out of the sanctuary. We have to be careful what we communicate. In fact, I heard about a sign on the wall of a hospital waiting room, if you can imagine this, that read this. It said, "If you're at death's door, our doctors will pull you through." Somehow, the more people thought about that, the less reassuring that was. In fact, it communicated exactly the opposite of what was intended. And there's a risk tonight that I will communicate the opposite of what I intend. Because whenever people talk about rationing, particularly if their best and their most realistic judgments tell them that rationing of health care is inevitable, people will misunderstand that and think that they're commending rationing, that they're approving and welcoming rationing. That's not my purpose here tonight, or ever. My concern tonight is that the challenge of health care reform in the United States today is greater than most people are willing to admit. Just as we assume and demand that medicine will cure everything that ails us, so we presume, I think now, that all we need is to identify that right health care reform proposal, and all will be well. However, all will not be well under any of the proposals. Many people will continue to be denied certain forms of beneficial care, which is how I would define rationing of health care, whether it's done explicitly or whether it's simply the result of the system at work, so-called implicit rationing of health care. Yet rationing is an issue that all of the reform proposals fastidiously avoid. And the result, I would suggest, can only be extremely dangerous. Let's take a closer look at what I'm talking about here. The inevitability of healthcare rationing has stimulated an almost paranoia about the economics of healthcare in a way that has almost relegated the concern for health itself to secondary status. And again, as so often the case, the comment pages tell the story. Physician turns to the patient and says, "You don't know how lucky you are. A quarter of an inch either way, and it would have been outside the area of reimbursable coverage." We've become preoccupied with the economics, for rationing itself has become inevitable. And I want to argue that that's the case for 5 basic reasons. The first reason I want to suggest that rationing has become inevitable has to do with the scope, the huge scope of current unmet healthcare needs. Rationing already exists on such a wide scale that the need for it is going to be virtually impossible to eradicate. Now, as a study published in this month's issue of the journal Health Affairs documents, over 21 million people in the United States now are going without health care coverage for more than a year. If we look at any given point in time, 37 million people in the United States are without health care coverage. And what does the figure look like if you look at all of those people who go without health care coverage at some point during a year's space of time? 57 million people in the United States are touched by that predicament, and another 20 million are underinsured. Now, a recent Office of Technology Assessment study documents how this lack of coverage has in fact led to reduced access to health care and to actual impaired health as a result. Rationing already exists widely, and it's extremely difficult to meet the entire need that lies before us in the face of the already huge costs of health care. So rationing, I'm suggesting, is inevitable. Physician turns to the patient now. Now then, before I give you my diagnosis, how much did you plan on spending? We become preoccupied with economics because rationing has become inevitable. A second reason for that I want to suggest. Reform itself will in some ways make the problem worse. Now, ironically, this outcome is due to one of the greatest strengths of proposals like President Clinton's. It has to do with an emerging awareness that our focus, our traditional focus on acute care medicine, on curative medicine, has led us to sorely neglect other very important aspects of health care. What have been some of those missing pieces? Well, we've paid far too little attention to supportive care, for instance, to pain relief and long-term care. We've paid far too little attention to preventive care. We've also neglected health promotion through healthy lifestyles due to our preoccupation with and faith in the saving power of acute care medicine. It's always there to back us up and to rescue us if we don't attend to these other kinds of priorities. I mean, we've had studies for decades, like Belloc and Breslow's study, which identified 7 key practices, lifestyle practices, or rules for healthy living and lifestyle behaviors. People who followed 7 of those rules, as it's been documented, are healthier and live longer than those who follow 6. Those who follow 6, more so than those who follow 5. In fact, let me just note a couple of the most striking findings of that classic study. They found that the physical health status of those over 75 who followed all 7 of those rules was about the same as those aged 35 to 44 who followed fewer than 3 of the rules. And a person who follows at least 6 of the 7 rules has an 11-year longer life expectancy at age 45 than someone who's followed less than 4 of the rules. And those differences remain constant across all socio and economic levels. I see what you're thinking. What are the 7 rules? You want to know, right? Okay, all right. The 7 rules are: don't smoke cigarettes, get 7 hours of sleep, eat breakfast, keep your weight down, not drinking excessively, exercising daily, and not eating between meals. People are checking off here, see how you're doing. Okay. Reform proposals like President Clinton's are to be commended for directing much greater attention and resources to supportive care, to preventive care, to health promotion. But one result certainly is that no plan can provide for every form of health care of all of these sorts that will have potential medical benefit. So I'm suggesting for the second reason, the nature of healthcare reform itself, that rationing is inevitable. This time, the physician's receptionist turns to the patient. Is he affordable? Heck yes. I think you'll find Dr. Feldman has a diagnosis to fit just about any income. The same trend being reflected here in our preoccupation with economics. This preoccupation is being driven by the fact that healthcare rationing has become inevitable. And I think that there's a third factor at work here. The third reason that I would suggest that healthcare rationing is inevitable has to do with the increasing availability and expense of medical technology. Now, while technological developments do sometimes replace more expensive treatments with less expensive ones, the more common scenario involves huge cost increases. In some cases, new expensive treatments like coronary bypass surgery or sophisticated brain imaging techniques like the MRI and the CAT scans, they only generate new costs. Well, they not only generate new costs on the one hand, but they also keep people alive longer to then eventually generate more healthcare costs. I know it's a stark and unpleasant observation to make, but death is the ultimate economy in healthcare. Now, forestalling death and alleviating suffering are excellent ends in themselves. I don't want to be misunderstood on that point. But as technology makes this possible in new ways, the costs mushroom. So the third reason I'm suggesting that rationing is inevitable has to do with the increasing availability and expense of technology. Give it to me straight, Doc. Can I afford it? Same scenario. We become preoccupied with economics, I would suggest, to a significant degree, for rationing of healthcare has become inevitable. And I want to suggest that that's the case for a fourth reason. The limited and temporary nature of the savings that can be achieved from efforts to remove waste from healthcare. I know there's a lot of talk about the waste that exists in healthcare today, and certainly there is a significant amount of it. But let's grant, first of all, some savings if people can be encouraged to pursue less expensive approaches to dying, such as hospice care. Let's also grant some significant savings if waste and excessive profits can be squeezed out of healthcare by restructuring the system and changing the financial incentives. And once those savings have been achieved, counterbalanced, I might add, by bringing huge new numbers of people and benefits into the system, then those savings are no longer available as a means to reduce costs. The waste has been eliminated from the system. So the relentless march of technology goes on and continues to cause overall healthcare costs to escalate. Now, this has been the experience already of other countries, such as Germany and the Netherlands, who realized, in fact, significant savings early on after adopting a more national approach to healthcare, but now are being forced to grapple with rationing certain healthcare benefits in the face of escalating costs. So again, a fourth factor as to why rationing is inevitable. The same portrayal appearing again. The physician, this time the psychiatrist. There's a slight chance you could be suffering from a dual personality, so just to be on the safe side, I'm going to charge you double. I know the physicians are going to say they're taking a bad rap. It's true. But I think what we're reflecting here is this preoccupation with the economics rather than the health of the situation, because rationing itself has become inevitable. And the fifth point that I want to make about that as to why that's the case has to do with the huge national debt that we're dealing with right now in the United States. That debt will require sacrifices in health care as in all aspects of life. We simply can't fund everything in health care or elsewhere the way we'd like to, and the way, in fact, that we could if we weren't so deeply in debt. So rationing, either explicitly or implicitly, I'm suggesting, is inevitable. So how is this predicament addressed in various healthcare reform proposals that are on the table today? Well, mention of the word rationing is in fact avoided like the plague. The word itself is often referred to as the R word, as if it's a swear word in and of itself. Oh, that doesn't mean that the proposals before us actually avoid rationing of health care. None of the proposals on the table now ensures that everyone will receive everything that's of medical benefit to everyone. Most of the proposals, in fact, are so brief and general that it's extremely unclear exactly who will get what. Usually some board is going to decide exactly how that's going to work in the future. Now, at least President Clinton's proposal, that massive proposal you hear referred to with the huge number of pages, has a lot more detail in it. So we can see, for example, and just taking that approach as an example, that adults will not receive eyeglasses covered. People of any age will not receive hearing aids. Rehabilitation services and therapies will only be covered following injury or illness, which usually means that birth defects or congenital problems will not be covered. The plan places limits on the number of days that's allowed for inpatient and residential treatment for mental illness. And there are limits and long-term care benefits that are provided. One person who has become a bit frustrated, I guess, with this proposal tried to portray it this way. What does it say? You have to... have to expect some cutbacks with the Clinton health plan. There's our CAT scan. Well, I don't think that that's in the plan, so I don't want to cite chapter and verse on that like the other examples I was giving you. But the point that I want to make here is that the rationale for these limits, even in the President's proposal, the rationale is not medical in nature. You see, these limits are imposed in particular situations regardless of whether there is in fact medical need that would justify care in that situation. In fact, the plan itself advocates premium caps. In other words, forced limits on what can be spent on health care in future years, meaning that even more rationing will have to be done in the future. Now, by what criteria is present or future rationing to be done in Clinton's proposal or in any of the other proposals that are on the table right now? Such criteria are never spelled out. So rationing decisions will simply be left to the guidance of whatever values are dominating the culture at that point in time. Now, traditionally, such values in the United States have prominently included three concerns that were singled out in the Declaration of Independence, something very familiar to any child who grows up in the school system: the notions of the commitments to life, liberty, and the pursuit of happiness. Now, those values, if still shaped by a biblical worldview, would prove helpful in making good, though tough, rationing decisions in the years ahead. But these values have been warped and redefined over time. Now, the Declaration of Independence states that, first of all are created equal, and secondly, that they're endowed by their Creator with certain inalienable rights, including life, liberty, and the pursuit of happiness. However, today, we're publicly losing the conviction that all are created equal, because we're publicly losing the conviction that all are created. And with the loss of God and people as creations of God, we lose the sure guarantee that every individual is necessarily important, that all must have life, that all must have liberty, that all must be able to pursue happiness. As a result, half-truths replace truth. Protections for some replace protections for all. A commitment to quality of life replaces a commitment to life. A commitment to autonomy replaces a commitment to liberty. A commitment to utilitarianism, or the greatest good for the greatest number, replaces the pursuit of happiness. And I want to take a few minutes to explain why each of these developments is, in fact, significantly dangerous in our cultural situation now, and as we head into the realm and the experience of healthcare reform. The first core value that I think has biblical warrant, in fact, is that value of life. Human life, we find in the biblical records, is created by God. It is called not only good, but very good. People are created in the image of God. We find that right at the creation. We find in the Genesis accounts that people are not to be killed. Life is not to be ended, because life itself is created in the image of God. And in the incarnation, we see God becoming a human being. We see Jesus at work in the world, healing people. Healing, in fact, even unbelieving lepers, extending even to the least likely and the least lovely. But if God as creator and redeemer of life is removed, well, then life itself loses its intrinsic significance. We begin to ask, well, what is it about life that actually makes it worthwhile after all? Well, the answer quickly comes, well, it's quality. It's the quality of life, of course. So life is worth pursuing if it has sufficient quality, but it's appropriate to discard where it does not. Now, such thinking, I would suggest, is unthinkable from a biblical perspective. Not because quality of life isn't important, but because the significance of every life demands that the quality of every life be improved as much as possible. Those with the lowest quality of life cannot be denied health care through rationing, or even denied life itself through euthanasia. But that is exactly where we're headed, as quality of life replaces life as one of the core U.S. values. Secondly, the second core value with biblical warrant, I would suggest, is that notion of liberty, or freedom, the same term, basically. There are two dimensions in a biblical perspective, I think, to freedom, and it's important to distinguish these two. What are sometimes referred to as freedom from and freedom for. I mean, there's a key dimension of freedom from in the biblical writings. We see the Exodus, a freedom from oppression, a freedom from slavery, very much a concern of God. We see the sabbatical year legislation. We see the year of Jubilee legislation. We see the calls of the prophets that people are to be freed from oppressive conditions and situations. Now, it's easy to assume that if what freedom is about is being freed from restrictions, from repression, from that which would tie us down or bind us to something, then that must include freedom from all standards. But the New Testament, especially the Gospel of John, is very clear on this point that there's no neutral ground here. It's not that you can be freed from all standards and commitments. One is either subject to God and committed to God's ways, or one is subject to self and selfishness, to sin and to the influence of Satan. Now, one is freed from bondage to selfishness so that we can care for the needs of others. There's a purpose to that freedom. It is a freedom not only from, but a freedom for something specific. And of course, interestingly enough, it's in that our true individual, personal fulfillment and peace lies. Now, contrast with that understanding of freedom, the understanding of freedom that's so common in the culture today, the understanding of freedom as autonomy. Now, autonomy comes from two Greek words, autonomos, self-law. The idea is that the self is a law unto itself, a moral law unto itself. That what matters is what the self chooses, and I make a choice, and what I choose is right for me because I chose it. That is the standard, that is the definition of the moral nature of an action. And it's so easy to lose sight then in that kind of framework of the fact of any sort of authority or content coming from God. The authority is myself. That is the basis for moral law and ethical norms. So one implication of that is that it's critical to protect people's freedom, to protect people's choices, including choices about the use of their resources. Those with resources, it's very important to protect their freedom, to use their resources to obtain health care. But, of course, those without resources then don't have the means to obtain health care, and that's the way it goes. They're free to die, to put it most starkly, but not free to live if the resources aren't available. The autonomy of some, in that sense, undercuts the liberty of others, and that's extremely problematic. The third core value that I just want to make some comments on here has to do with that notion of the pursuit of happiness. Now, at least the notion of happiness, or human well-being itself, I would suggest is a biblical concern, as long as the well-being of everyone is in view. God is repeatedly portrayed in the Old Testament and the New Testament as concerned that even the lowliest shouldn't go without food or shelter or clothes, and health in particular appears to be a special concern of Jesus, who in his healing ministries addresses the needs of the whole person. But in the United States today, a utilitarian mindset predominates. As long as every person is not a sacred creation of God, then we can settle for attending to the majority, basically. The greatest good for the greatest number. As long as most people are happy, well, then that's sufficient. We're not comfortable that tens of millions of people go without health care coverage, but as long as they represent a minority, there's no compelling moral need to change the system. One visitor to the United States, if you can believe this, described it this way. Most Americans feel okay about pushing people out of the lifeboat. They just don't particularly like to hear the splash. What a chilling characterization. What will rationing look like in a culture more concerned about quality of life, autonomy, and utilitarianism than life, liberty, and the pursuit of happiness? Well, I would suggest concretely that it will look very dangerous for those groups who are demeaned and devalued by those half-truths. In particular, three groups I would suggest: disabled people, poor people, and elderly people. And I just want to explain how I think that flows from the cultural situation that we're in right now. First of all, disabled people. Where quality of life is a governing value, those whose quality of life following treatment will be lowest are going to be the first to be denied treatment. Disabled people necessarily fare poorly in this way of thinking, for their quality of life in certain respects tends to be diminished or limited. Now, when the state of Oregon developed its first so-called Medicare rationing proposal, explicit quality of life standards played a prominent role, and that was played up quite significantly in the press. Now, this proposal was rejected at first by the federal government because of the obvious ways that such appeals to quality of life discriminate against persons with disabilities. However, the proposal was later accepted when quality of life considerations were only included more subtly. Now, quality of life standards are similarly subtly at work in national reform proposals on the table today, like President Clinton's. The presidential proposal adopts a standard of, as it says, medical necessity or appropriateness for eligibility for treatment. Now, according to Hillary Clinton's recent testimony to the U.S. Senate Finance Committee, the standard of appropriateness is to be understood in terms of impact on quality of life. So it's not surprising to see the exclusion of many therapies and mental health benefits, as I noted earlier, from the proposal, or to see the discrimination on the basis of disability is omitted from the list of discriminatory grounds on which a patient is allowed to sue a health care plan. Now, where quality of life displaces life as the reigning standard, disabled persons, I'm suggesting, will be at grave risk as the economic pressures on the system rise. Consider, secondly, the risks to poor people. In a culture preoccupied with autonomy, we become hypersensitive about infringing on people's rights to choose to do what they want to with what is their own, irrespective of the consequences for others. So we protect people's rights to abortion, regardless of the implications for the fetus, and we protect people's rights to pursue only their own health care, regardless of the implications for poor people who can't afford health care coverage. Now, this is perhaps, I would suggest, the most deceptive form of rationing today, because we so often fail to see it and identify it as such. We're not explicitly refusing health care to people today, we say. It just turns out that poor people have less access. What we fail to see is that in our self-preoccupation, in our reverence for autonomy, that ensures that practices and policies and systems will develop in a way that those without the resources are left at serious risk. That's the way it turns out consistently. And consider finally the impact on older people. In a utilitarian culture, the greatest good for the greatest number rules. And that mindset dictates that people's value is based upon what they contribute to society. Achievement and economic productivity are highly valued in the United States. So those who contribute most in those terms are most worthy to be sustained by society's resources. Those who are older and who are said to have passed their economic prime are devalued in that way of thinking. And accordingly, numerous public policy proposals have been put forward in recent years. Proposals to explicitly ration health care according to age. And the administration has publicly committed to significantly cutting Medicare resource expenditures. And interestingly enough, in the broadest statement prohibiting health plans in the presidential proposal from discriminating on such bases as race, national origin, gender, health status, all of which are spelled out there, there's no mention of age. as an illegitimate basis. All of this is to say that as quality of life, autonomy, utilitarianism replace life, liberty, and the pursuit of happiness as the aspirations of this culture, people who are disabled and poor and elderly or otherwise marginalized are especially at risk. Yet it's precisely those who are so marginalized, those who are poor in terms of their ability to produce what is valued by the culture, those are the ones that Christians are exhorted in the Scriptures especially to protect. Defend the cause of the poor, challenges Jeremiah. Rescue the poor, implores the psalmist. Give to the poor, suggests Matthew. Remember the poor, reminds Paul. Doing so may not come naturally. We're so easily preoccupied with our own needs and our own perspectives and insensitive to the needs of others. You know, I recently heard about a man who was waiting for his first child to be born. He wasn't in the delivery room, he was out in the waiting room, and he was pacing back and forth, nervously wringing his hands, perspiring profusely. After what seemed like an interminable length of time, the nurse stuck her head into the waiting room and said, "Congratulations, sir, you have a baby girl." To which he immediately responded, "Thank God it's a girl. At least she'll never have to go through what I've just been through." That's the way we are, so preoccupied at first blush with our own needs. But let's pray and endeavor to be more, that we could respond faithfully to what I'm suggesting is a twofold challenge. First of all, to critique and to stand against the misleading values of the culture. And secondly, to speak out in behalf of those devalued by the culture who will bear the brunt of healthcare rationing in the future.
This is with regard to your first point, saying that the disabled persons will be discriminated against. But what about the trend exemplified by the famous Americans with Disabilities Act, which prevents that and, for example, also includes such things as AIDS as a disability? How do you react to that?
Right. Well, it's interesting to see how that functioned in the Oregon situation, in that the initial Oregon proposal was turned down precisely on that basis. So where that value is blatantly invoked and where people with disabilities are blatantly discriminated against, it's just simply too obvious on its face. I think you can see analogs to other issues in our country where blatant examples of racism or blatant examples of sexism, when we look at square in the face, I think we still have that resonance of that heritage in the country where we recognize there's something wrong here. But I think what is increasingly shaping our values, our intuitions, and our decisions, where it's not so blatantly lifted right in front of us, is precisely that kind of quality of life thinking. So therefore, you see the Oregon proposal coming back with the explicit language taken out. But in fact, and I discussed this at some length with the person who was responsible for the rewriting of that proposal, they said, in fact, quality of life considerations were very explicitly considered. They just weren't labeled as such in the proposal. So I think we still have that, ambivalence. We still have a sense that there's something problematic here if we stare at it square in the face. But in fact, the way it operates in the culture, and I would suggest will increasingly operate, is at a much more subtle level, where I think it'll do much more damage.
Thank you.
John, I just have a comment in the area of rationing on the ability to pay. In 1985, Congress passed a law that requires emergency rooms to provide coverage or provide care to everybody that comes to the door. Now, you can argue that that's not a rational way to finance, but it's not an access problem. So I think that it's only fair to say that nobody, at least the way the laws are structured in this country, go without care in the United States. And I think we have to be fair on that. Now, it may not be the most rational way to finance, since emergency rooms are 2, 3, 4 times higher. But there wasn't a conscious attempt by Congress to mitigate the severity of the ability to pay, which is sort of a characterization that I think is not always fair of the United States healthcare delivery system.
Yeah, I think that's a good observation, that in fact the situation isn't nearly as bad as you might think it would be with so many people without health care coverage. If for one reason it's because of the emergency facilities that are available. It also has a lot to do with the huge number of physicians and others who are providing care free or at virtually no cost, and so they're making it available even for people who don't have the coverage. However, it is true, nevertheless, for a variety of reasons, that there is a correlation, a statistical correlation, between less health care coverage, less access to health care, and lower health. And I think that has to do with a lot of reasons. It's not because it's always the case that there is no health care available, but it may not be available in their area. It may not be accessible for various reasons. People may have experienced in the real world going into emergency room and having horrendous experiences there, so not going back. There's all sorts of reasons.
I think one of the reasons that we haven't provided it, and frankly ought not provide it as such, is that people have to make choices. They have to lead their lives with some responsibility for themselves. We've provided a system which I would agree may not work perfectly efficiently, that provides basic care to everyone. But if we go to a system of universal coverage with universal benefits that are the same for everybody, what will inevitably happen is that the quality will fall dramatically, because there will be no reason for people to provide for their health. They're going to get the same care one way or the other. And a large number of people on the margins will shift to less healthy habits. You talked about the 7 things that make you healthy. We've known those for a long time. We've told everybody those things. You can't, education doesn't work, and it particularly doesn't work when you take away the cost of failing to do those things. So that this is the reason why many of us would say that all that this is an attempt to socialize medicine, which will be to our great detriment, as it has been, I think, in most other countries where we've gone to, where they have gone to socialized medicine.
I want to affirm those concerns, because I think what we're dealing with here is a multiple set of moral concerns. That's why I would not, and I certainly wouldn't hope that you took me as saying that what we're finding, in fact, in the presidential proposal is the way to go, that we should adopt that kind of system. I think what we're dealing with are multiple problems. On the one side, we're dealing with people who are being left without health care to their detriment. On the other side, to simply hand it to everybody, guarantee it to everybody, to develop a system in which there was nothing at stake and no reason and no incentive to pursue healthy lifestyles, is going to create problems on the other side. And so I think that is the challenge that lies before us now, is I think it's too simple to let people fall out on either side, to leave people without responsibility, or on the other hand, to leave them without the means to provide their health care. And some of the most creative work, I think, that's going on in some of the proposals that are coming on the table now are falling in that middle ground. They're asking those questions, and I think that's what we need to do. That's why my concern, even tonight, was to focus on, and I think that's the challenge for us now, is to focus on the moral issues, to lift those up, because I think we're not talking about one proposal that's going to be voted in lock, stock, and barrel. We're going to see, I think, a lot of shifting and adjusting, and the question is, what are the key moral concerns that final proposal is going to have to address? So I appreciate your bringing out the fact that if you go along that spectrum of just handing everything to everybody and don't build in any measure of accountability or responsibility, then you've swung too far in that direction, and that's very important.
Listening to all of the issues with healthcare, I had an interesting conversation with our health commission the other day at work, and one of my concerns, one of the things I think with healthcare is that the faith communities have to get back and take accountability for healthcare. And the CEO of our hospital, I was challenged by the reinventing that we're doing in our big institution. And I said, you know, it's kind of like it's come to time to where we have to knock down the walls and go out into the community. One of the things that I'm interested in as a nurse in advanced practice is looking at parish nursing. And I'm just interested if you guys have either one comments on how that could help with where we are in healthcare using advanced practice and using the faith communities in setting up like parish nurse programs or whatever.
I just want to strongly affirm the parish nursing program. I think that is an excellent way for the church to address this question because it brings the healthcare into the community. It addresses the whole person, the needs of the whole person, rather than segmenting off the physical dimension, and actually brings that health care where the people are living and where the need is. And I think part of the problem, going back to Scott Daniels' question earlier, why people aren't getting it even though it's there, even though Congress has mandated that emergency room be open, is that it's over there and it's insensitive to their needs. So I think it's an excellent model, very needed.
I just wondered if the American government has any strong proposal to allocate huge numbers of dollars to prevention.
In fact, part of what is evident in proposals like President Clinton's proposal is a much increased emphasis on preventive care. And I think the recognition there is one that in the long term, not only for human well-being, which is important in itself, but also in the long term, that can even be cost effective, that you can save larger costs later on by certain types of preventive care. Now, certain types of preventive care increase the costs, but many do in fact save the costs, and I think those are the ones where the intention is to target those. The problem, again, is that you have to invest more up front in order to save more later, and that's precisely the economic crunch we're in now, is to be able to pull that off. It makes sense, and certainly makes good long-term sense, but look at the national debt we're in right now to see whether, you know, the basic governing mentality is that long-term perspective. You know, it's not. That's part of the problem.
I just have two questions. One of them is to the theologically minded, which I think all of us are to some degree. First of all, how or what criteria did Jesus use to ration health care that he provided, and then what impact does that have on our discussions here in that regard? And the second one is, how do we regard health care in regards to rationing? Is it considered to be a right or a privilege? And I think there's a difference between those two, or is it just a generous compassion? And then what restrictions do we put on those who are generously compassionate in their delivering of health care?
What you do not see in Jesus is that option for rationing people, which has been so characteristic of basically the way the system has operated. What I think is problematic about rationing people, which ties into the second question, is that I think health care is one of those kinds of basic needs, health, that we need in order to function as human beings. And we see addressed in Scripture, and we have to have food to function as human beings. We have to have shelter to function as human beings. And so those things, whatever they are, that are essential for us to be able to function as human beings, to exist as human beings, as God has created us to be. Not to flourish and not to have the greatest and highest levels of everything, but to be able to basically function as we're intended to function. Those things have a special moral status. You know, what we want to call them, there's a problem tying into the whole rights language debate, which is a very self-centered, individualistic orientation and approach. It's a half-truth, like so many of these other moral concerns we were talking about today. The truth that it picks up on, though, is that I think that healthcare is something of fundamental importance, and therefore something that God is concerned about, that every person would have just as shelter and food is addressed for those who are going without throughout the biblical writings.